Good afternoon and welcome to this webinar on cardiovascular toxicity induced by anti-cancer treatment. As you know, improved cancer prognosis due to the advance in early diagnosis and cancer therapy goes end by end with increased cancer survival. At the same time, cardiovascular morbidity is increasing among cancer survivors as a result of the cardiovascular adverse effect of anti-cancer drugs. This is often the result of mechanisms that are still partially unknown, which hinder the development of preventive and curative therapies targeting the specific cardio and vasculotoxicity effect of anti-cancer therapy. In this webinar, we will discuss the new frontiers of cardio-oncology research, the mechanism and implication of hidden cytotoxicity, and the metabolic route of anthracycline-induced cardiotoxicity. This topic will be addressed by world-renowned experts in the field. My name is Rosalinda Madonna. I am Associate Professor of Cardiology at the University of Pisa, and I am pleased to co-chair this session with Professor Federico Carbone, Associate Professor in Internal Medicine at the University of Genova.
Okay, thank you again for that lovely introduction, Professor Madonna, and I'm sorry for interrupting you. I will keep it as brief as possible. So thank you very much for joining our webinar today on updates on cardiac and vascular toxicities from antineoplastic drugs. So first of all, just to give you a very brief update to MDPI, we are a pioneer in open access publishing, and we started in 1996 with our headquarters based in Basel in Switzerland. Our mission is to foster this open scientific exchange in all disciplines, and we now have 473 diverse open access journals, including 464 peer-reviewed journals and 9 conference journals. And these are supported by more than 115,000 academic experts who share our mission, values, and commitment to providing high-quality service. So the Journal of Clinical Medicine is supporting this webinar, and we're an international peer-reviewed open access journal. We publish in all fields of clinical medicine, and we are published semi-monthly online. So today we've had an introduction by Professor Rosalinda Madonna, and then we will go on to our talks from Professor Ameri on the perspectives of cardio-oncology research. This will be followed by a 20-minute talk from Professor Peter Ferdinandi on hidden cardiotoxicity of drugs. And our last talk will be by Professor Emilio Hirsch on doxorubicin cardiotoxicity and cardiac metabolic rewiring. After this, we'll have our Q&A session, and then we'll have a closing of the webinar done by our chairs, Professor Rosalinda Madonna and Professor Federico Carbone. So our chair, Professor Madonna, has a special issue on clinical updates on cardiac and vascular toxicities from antineoplastic drugs and beyond. And this is a special issue that's linked to this webinar. In case anyone would like to submit an article to the special issue, you can find it on the JCM website at mdpi.com/journal/JCM. And that's open for submissions until the 25th of January 2026. And one quick note, if you want to ask any questions during these presentations, as I said before, all of the questions will be taken at the end. So please just pop any questions you've got in the Q&A chat, and we will be glad to answer them all at the end of the session. So now just an introduction to our 2 chairs today. So Professor Madonna is an assistant professor of cardiology at the University of Pisa and is qualified as a full professor in cardiology and a full professor in sciences of the health profession and applied medical technologies. She is also a consultant at Cicinello Hospital in Pisa. After receiving her degree in medicine and surgery, she also achieved a master in internal ultrasound and a PhD in biotechnology and functional bioimaging. Following this, she completed a number of postdoctoral research fellowships at the University of Texas Medical School and at the Institute of Molecular Cardiology at the University of Louisville. She then returned to the University of Chieti, where she completed her specialization in cardiology before starting work as an adjunct assistant professor at the University of Texas Medical School and as a research scientist at the Texas Heart Institute. And then finally, prior to her current position, she was made an honorary researcher at the University of Chieti and worked as a senior research scientist at the University of Pisa. Our co-chair, Professor Federico Carbone, is an associate professor of internal medicine at the University of Genoa and a consultant in internal medicine at the IRCCS Polyclinic Hospital San Martino. After completing his medical degree and his residency in internal medicine at the University of Genoa, he earned a PhD in cardiovascular biology through a joint program with the University of Geneva. His research focuses on cardiometabolic medicine, and he has particular interests in inflammation, obesity, and atherosclerosis. Professor Carbone also serves as deputy editor for the European Journal of Clinical Investigation and has held multiple leadership roles within the European Society for Clinical Investigation. So thank you very much for chairing this session today, and we will now pass on to the first speaker.
Okay, so thank you, Professor Madonna, for the kind invitation, and thank you for the introduction. And I'm pleased to be here with you. So these are my conflicts of interest, which are not related to the topic I'm going over today. So during this talk, I will focus on some areas of cardio-oncology research, which I think might be of particular relevance in the next future. Of course, I will not cover many others, and I apologize in advance if I'm not touching upon important points. I will jump from the bench to the bedside and vice versa, because cardio-oncology has always been characterized by the strong interconnection between preclinical and clinical studies, which I think is a major strength of this area of cardiovascular medicine and science. So I will go over these three points. First, the need for standardized and harmonized data collection. Second, the need for randomized controlled trials. And the third, I will briefly discuss the concept of bidirectional cardio-oncology, which implies a greater vision, but also greater complexity. So starting with the first point, we have plenty of cardio-oncology data. The field is really blooming, and every day we can read the new papers on the topic. Unfortunately, many times the information we have is not really exploitable. This is especially the case with preclinical cardio-oncology. There are reports of several, literally thousands of experiments, which, however, outnumber the profitable results, the results that can be exploited by other researchers, by funding agencies, by pharmaceutical companies, and so forth. And this limitation has two main reasons. The first, too often experiments are performed not in a rigorous way. This is a problem which is transversal to many sectors of science, and of course is not just specific for cardio-oncology. The second reason why we have more experiments than profitable results is that not infrequently the choice of the model or the models used to test a certain hypothesis, the study design, the endpoint that are adopted are suboptimal or anyway not the best to investigate that certain question in preclinical cardio-oncology. We have plenty of available models to study the cardiovascular side effects of cancer treatments. And here you have a very nice figure from a recent paper published by Alessandra Rigu and other colleagues from the European Heart Failure Association, were the advantages and the disadvantages of several different preclinical models to study cancer treatment-related cardiovascular toxicity are discussed. When choosing one of these models to study cancer treatment-related cardiovascular toxicity, we should spend a lot of time in reasoning on the pros and cons based on which we might choose for that model. And some of these considerations are general and are the same that apply to other fields of cardiovascular science. For instance, we all know that different types of cardiovascular cells have profound differences, although they are generally used to mimic the same cardiovascular cell population. For instance, here you have a very nice overview. Let me put this down. You have a very nice overview of how different types of cardiomyocytes obtained from patients, from rats, and from mice have striking and remarkable differences regarding their contractile structure, their profile of gene expression, and their response to ischemia, reperfusion, and angiotensin II or isoprenaline. And we have to keep this in mind when we consider, when we try to compare results obtained with one of these cell models with the results obtained with another cell model. So, and this, of course, is a general consideration, which, as I already said, is true for any study in preclinical cardiovascular science. However, there are also considerations regarding the model and the study design that are specific for preclinical cardio-oncology. First of all, we have to bear in mind that in most cases, cancer treatments are administered by protocols where a certain drug is given many times over time with repeated infusions or administrations. The typical example is the one of chemotherapy, which is given by cycles every some weeks. But even oral therapy, for instance, with tyrosine kinase inhibitors, is given by daily oral administrations. So anytime we try to model cancer treatment-related cardiovascular toxicity in the preclinical setting, we should aim at administering our cancer treatment with a schema of repeated pulses rather than a single administration. Second, we have to consider that the pharmacokinetics of cancer treatments in humans, in patients, are relevant as far as the potential cardiovascular side effects are concerned, and again, should be somehow recreated in the preclinical setting. For instance, doxorubicin, the anthracycline that is most widely studied in preclinical cardio-oncology, is administered intravenously to patients. It reaches a very high concentration in order of micromolar ranges in the very first hours after intravenous infusion, but then goes down to a range of sub-micromolar, nanomolar range of concentration. And this is the range of concentration at which the drug persists in tissues, including cardiovascular tissues, for days. So when we study the effects, the potential cardiovascular effects of doxorubicin, we should try to use concentration in this range rather than in the range which is reached only in the very acute phase post-infusion. And of course, we also have to consider that any model we use, cell model, animal model, presents intrinsic differences in terms of response to the effect of a certain cancer treatment. To make an example, here you see data from my own lab, and you have the graphs show the effect of doxorubicin administered 3 times over 2 weeks to female BALC or FB mice. So we are treating mice in both cases. The only difference is the strain. And you can appreciate how the reduction in fractional shortening, the measure of left ventricular systolic function, is different from one strain to the other one. And this is just because of the intrinsic differences of the two strains in terms of left ventricular systolic function. So why I'm making all this consideration? Because recently, the basic and translational study group of preclinical cardio-oncology, part of the Council of Cardio-Oncology of the ESC, has teamed up with the ESC Council of Basic Cardiovascular Science and with a panel of international experts to outline possible quality standards to guide preclinical research in cardio-oncology. The aim of this document is to give important indications on which are the best models, study designs, and endpoints to use to study different types of cancer treatment-related cardiovascular toxicity. The document is now undergoing the publication process. We hope it'll come out soon, and we hope help to promote the collection of more standardized data in preclinical cardio-oncology. Of course, the problem of standardization relates also to clinical cardio-oncology. There are many different observational studies that have given information on the patterns of cancer treatment-related cardiovascular toxicity in patients. I've just mentioned a few here. And in principle, information which is important for cardio-oncology could also come for oncology randomized clinical trials, as well from cardiology randomized clinical trials. The problem is that the type of information collected from these different types of studies, observational studies, randomized clinical studies, studies in the oncomatology field, studies in the cardiovascular field, is different and often is quite disconnected. So it's very difficult to pull together a minimum data set that could be used to gather information in cardio-oncology. Just to try to clarify the concept by showing a very simple drawing, we have different studies, A, B, C, D, E. And let's say that one study is an oncology trial. The second study I'm pointing to is an observational prospective study in cancer patient. This is a cardiovascular trial. This is a cardio-oncology study. And this last one is a study on arrhythmia. And we may envision a scenario where all studies provide a minimum core of data that can be used to expand the knowledge in cardio-oncology. And then there will be further data that will be different across studies. So this core data set may be very valuable to rapidly strengthen our knowledge in cardio-oncology. And this is another important direction towards which cardio-oncology researchers are moving. There have been attempts to define which the core cardio-oncology data can be. This is, for instance, a table from a recent document recently published in JACC Cardio-Oncology. And let's say that we are on the way to define this minimum clinical data set to harmonize and standardize data collection in cardio-oncology. So I've touched upon the standardization and the harmonization of data collection in the preclinical and clinical setting of cardio-oncology. Of course, it's also important that the two fields are related to one another. As I said at the beginning, preclinical and clinical cardio-oncology are intimately interconnected and should remain so. This is probably not the case at present. This is a very simple analysis we performed recently, where we we assessed the focus of preclinical cardio-oncology studies versus phase 3 randomized clinical trials in oncology or oncohematology over the last 4 years, 2021 to 2024. What we found that the vast majority of preclinical studies was on anthracycline in red, especially doxorubicin, while phase 3 oncology randomized clinical trials published over the same time period were mainly on immune checkpoint inhibitors, blue, tyrosine kinase inhibitor, green, alkylating agents, yellow, and antimetabolites, orange. So there seems to be quite a strong disconnect between the objects of preclinical studies in cardio-oncology and the focus of randomized clinical trials in oncology and non-hematology, and which implies that there is a mismatch between the direction that preclinical cardio-oncology is following and the direction that the development of clinical therapeutics, oncological therapeutics is following. So again, something where there is need to work. Then my second point is randomized clinical trials. So cardio-oncology is, we must admit that, politically lacking good randomized clinical trials. And I'm not just talking about randomized clinical trials comparing a certain intervention against no intervention, drug versus placebo, or two different interventions, let's say drug A, drug B. I think that cardio-oncology primarily needs randomized clinical trials regarding management strategies or even more. Let's start with management strategies. And to explain this consideration, I will briefly touch upon the possible cancer treatment-related cardiovascular toxicity of immune checkpoint inhibitors. So it goes without saying that immune checkpoint inhibitors have literally revolutionized the prognosis of many cancer and are becoming the cornerstone of the treatment of several different types of malignancies. The common mechanism of action of any immune checkpoint inhibitor is to inhibit specific molecules, PD-1, PD-L1, CTLA-4, and also LAG-3, that block the immune response against tumor orchestrated by T cells. So these drugs unleash T cells against tumors and therefore promote anti-tumor immunity. This comes at the price of possible immune-related adverse events due to the unwanted activation of immune cells in other organ systems. And one of the most known and feared immune-related adverse event on immune checkpoint inhibitor is myocarditis. The first report about immune checkpoint inhibitor-related myocarditis were really dramatic. Were about patients who were diagnosed with crushing clinical presentations and eventually died because of immune checkpoint inhibitor-related myocarditis. Although this type of complication is not necessarily so severe. There may be cases of extreme severity, so-called grade 4 cases, but many cases are just grade 1 and grade 2. So this grading is the grading that is generally used by oncologists to stratify the severity of adverse events of cancer treatments, regardless of which organ is involved. And grade 1, in the case of myocarditis, is just an isolated increase of cardiac biomarker, like troponin, without symptoms or HCC abnormalities. This is not uncommon, especially since measurement of troponin is recommended by many guidelines, including the one from the European Society of Cardiology, to monitor patients receiving immune checkpoint inhibitors who are at higher risk of developing cardiovascular disease. So this is the scenario, and at present, for any immune checkpoint-related myocarditis, it's recommended to withhold the treatment with immune checkpoint inhibitor and start intravenous corticosteroid therapy, high-dose intravenous corticosteroid therapy. This is based on few retrospective studies. The greatest one is the one I'm showing here to the right, where a small cohort of 126 patients with severe immune checkpoint-related myocarditis received or did not receive intravenous high-dose corticosteroids. And you see here that those who were treated with high dose of steroids had better survival. And this was especially the case with those who were treated within 24 hours after presentation. Of course, this is a retrospective study biased by the fact that at that time, only severe cases of immune checkpoint-related myocarditis were detected. And this is why there are different positions regarding the use of corticosteroids in patients with mild myocarditis, grade 1 immune checkpoint-related myocarditis. While the ESC guidelines tend to recommend the use of corticosteroids at high dosage and early administration in any patient presenting with isolated myocarditis, including those asymptomatic. The guidelines from the Association of Clinical Oncology of the USA or from the National Comprehensive Cancer Network, another association in the USA, are more cautious and suggest to limit the use of corticosteroids only for patients who have grade 2 or even grade 3 myocarditis. Of course, clearly here the challenge is covered by the icon here. Anyway, it's to find the balance between the risk of over-treating patients, so giving them corticosteroids and stopping immune checkpoint inhibitors, even when myocarditis is very mild and probably would recover without an intervention. And on the other hand, there is the risk of under-treating patients, so being too confident the myocarditis will resolve and not promptly treat cases that then progress to severe scenario. So this is the context where I think we really need randomized clinical trials comparing different pathways of care. Should we manage patients with grade 1 asymptomatic myocarditis with corticosteroids, or should we just wait and start again therapy, immune checkpoint therapy, as soon as the troponin concentration normalizes? And cardio-oncology probably is also one of the fields where we also need broader trials, if it's possible to make them, comparing pathways of care. So now, at present, we try to predict the risk that a certain patient with cancer will develop cardiovascular toxicities due to the therapies he or she is receiving, based on some factors. Those who are related to the patient itself, age, presence of pre-existing cardiovascular factors of cardiovascular disease, and of course, cardiac status. And those which are related to the characteristic of the treatment. Clearly, a treatment which is known to be strongly cardiotoxic, like anthracycline, is more likely to cause problems than the treatment with minimal or no known cardiotoxicity. And there are many efforts to expand our capability to predict the risk of cancer treatment-related cardiovascular toxicity by incorporating other factors into the equation, like the genetic background, the accessibility to healthcare by the patient, and so forth. So let's say that we are successful, and point by point we add new factors and refine our prediction of risk. So for a certain patient, instead of classifying the patient as low or intermediate risk, we can be more precise and say, well, it can be at intermediate or high when I had my additional factors to stratify. And then what do? Should we surveil the patients in a more closer manner? Should we lower the threshold according to which we prescribe cardiovascular medications? We cannot answer these questions, and we would need, again, a randomized clinical trial comparing different pathways of care, one based on the traditional risk assessment and one based on the more complex, more granular risk assessment. Finally, my last point, bidirectional cardio-oncology. So there is a number of studies suggesting that pre-existing cardiovascular disease promotes the growth of cancer. These are epidemiological studies. The type of cardiovascular disease that has most strongly been associated with the incident cancer is heart failure. You see to the left the summary of a study we performed in Italy, and to the right a meta-analysis, including the results of the study I just mentioned, showing that patients who have heart failure have a higher risk of being diagnosed with cancer and dying from cancer during follow-up as compared to control subjects without any heart failure. And there are possible biological pathways underlying this association. This cartoon summarizes the main hypotheses that have been drawn so far based on very good, I would say excellent preclinical studies. So some authors were capable to point out soluble factors released from the failing heart that favorably modulate the growth of tumors, and for instance, serpin A3 or periostin. And other authors pointed to the importance of a rewiring of the immune system caused by the failing heart that modifies the tolerance of the immune tolerance towards the tumor. In other terms, when there is heart failure, the immune system is reshaped and becomes more tolerant towards the presence of a tumor, and because of that, the tumor grows more and metastasis. It's really difficult to dissect the specific role, the relevance of these possible factors. Recently, Eva Bianconi from my lab tried to further answer the question of whether the immune system is relevant or not in promoting tumor growth when there is heart failure. So she subjected fox null mice, which are immunocompromised mice, to coronary artery ligation to reduce pathological cardiac remodeling and therefore heart failure or shunt surgery. And thereafter, she created a xenograph of MCF7 mammary cancer cells, human mammary cancer cells. And she monitored the mice for cardiac function on the one hand and tumor growth to the other end. These mice do not have a significant immune response to any tumor since they are immunocompromised. You can see on the top of the slide, you can see that mice that were subjected to coronary artery ligation underwent cardiac remodeling with left ventricular systolic dysfunction and left ventricular dilation, as expected. But there was no signal for a significant difference in tumor growth between animals that were subjected to, let's say, heart failure and animals that were subjected to shunt surgery in purple. And this was despite the worst hints for a reduced rate of apoptosis in the tumors of mice subjected to heart failure as compared to mice subjected to control surgery. And there was also evidence of increased proliferation and increased expression of genes related to proliferation in the tumors of mice that were subjected to coronary artery ligation. So these results suggest that the immune response is quite important to modulate the growth of tumor response to heart failure, and therefore that, going back to this cartoon, it's a mixture of different factors, among which modulation of immunity that drives the association between cardiovascular disease and cancer. And this is just a part of the story, because we can spend more time, this is my last slide, I swear, we can spend more time on discussing, on reasoning on other possible biological factors and pathways driving the association between heart failure or other types of cardiovascular disease and cancer. But there are additional entities that probably should be considered: clonal hematopoiesis of indeterminate potential, environmental determinant of health, social determinants of health. So all these factors probably contribute to the bidirectional link between cancer and cardiovascular disease, so-called bidirectional oncology. And this is definitely a challenge for preclinical cardio-oncology research in the next future, to embrace a greater vision, which also implies greater complexity of modeling and of understanding. Thank you for your attention, and I invite all the colleagues who are following the webinar to join the ESC Council of Cardio-Oncology, which is free.
Thank you very much, Pietro. Thank you very much, Professor Ameri. I would like now to give the talk to Professor Carbone, my co-chair, for some question or for introducing the next speaker.
So we'll tell about the question was for the final part of the webinar. So I would move on with the next speaker, Peter Ferdinandin, which is clinical pharmacologist. He's a highly cited researcher. In the last year, published more than 350 papers, and he comes from the Sunrise University of Budapest. He is president of the International Society of the Earth Research, European section, the chair of the working group of cellular biology of the Earth of the European Society for Cardiology. So I call him for his talk entitled Hidden Cardiotoxicity of Drugs, a Paradigm Shift in Cardiac Safety Testing. Thank you.
Yes, thank you. So after the great talk of Professor Amari, I have a little more broader view of cardiotoxicity of drugs, not only oncology drugs, because we think that there is a need for a paradigm change in cardiac safety testing. These are my disclosures. Actually, to introduce cardioprotection and cardiotoxicity, I have this short slide that, if there is an ischemic heart, the longer the ischemia lasts, the more cardiac cells will die. And currently, reperfusion is the only way to protect the heart. However, ischemia reperfusion injury is still a clinical problem. And although we know that it's possible to reduce ischemic reperfusion injury, so infarct size, there's still no drugs on the market. So we know that there are several methods to protect the heart, like ischemic preconditioning with brief periods of ischemia before the lethal ischemia or during or after reperfusion, but there is still no cardioprotective drugs. However, ischemic reperfusion injury can also be aggravated by several factors. These are cardiometabolic risk factors and drug treatments as well. So, for example, it has been shown that diabetes mellitus or dyslipidemia may increase the size of infarction, so they may make the heart more susceptible to ischemic reperfusion injury. And so are some drugs also able to aggravate ischemic reperfusion injury. And the problem is that in routine preclinical cardiotoxicity screening of drugs during the development, these methods are not able to detect these effects. And therefore, we termed this hidden cardiotoxicity, meaning that those cardiotoxicity which manifests only in the diseased heart, but not in the healthy heart. So in this slide, you can see the process of drug development, where this is a very expensive and costly process. And the current preclinical safety testing is done before it turns to the clinical trial, so still in the preclinical phase. But the problem is that several cardiotoxicity of the drugs under development reveals only at the late phases of the clinical development, or when the drug is already on the market. And in fact, still, according to some estimation, the unexpected cardiotoxicity accounts for 60% of drug withdrawal from the market, and the termination of clinical trials are due to this unexpected cardiotoxicity, which unfortunately we were not able to reveal during the preclinical testing. So the cardiotoxicity of drugs is still an unsolved safety issue, and the problem is that we do not really know the mechanism of the effects, so the mechanism of the cardiotoxic effects. So this is still a clinical problem, because drugs still on the market with cardiotoxicity as a side effect is well known, but we still, of course, use this drug because there are no better drugs, but we need to develop some drugs with better safety profile. And there's also an economical problem because of the side effects, of course, but also because the drugs withdrawn from the market due to cardiotoxicity. There's a long list of these drugs. And, this is a sunk cost for drug development when you have to terminate at the very late phase during a clinical trial, or even worse, when it's already the patients were exposed to these drugs. So we introduced this term hidden cardiotoxicity, which is cardiotoxicity of drugs that manifests only in the diseased heart. It can be during ischemia, reperfusion injury, or in the presence of any major comorbidities, which leads to cardiovascular disease. So this is the first paper in European Heart Journal on this phenomenon, and this is just a summary slide how it looks like. So the drug-induced cardiotoxicity is what is known currently and is tested, is that when there is a drug and it directly induces cardiotoxic signaling and leads to death of cardiac myocytes or electric imbalance, and therefore they may cause myocardial infarction, heart failure, or arrhythmias. However, there are hidden cardiotoxicity signaling. I will show you the first example when we show the COX-2 inhibitors, for example, when the deleterious cell signaling is aggravated by these drugs. For example, ischemia induced by ischemia reperfusion injury, and also aging, diabetes, hyperlipidemia, and so on. Many of these risk factors may be able to increase the deleterious cardiac cell signaling, and therefore they leads to more death of cardiac myocytes. And on the other hand, some drugs may inhibit the cardioprotective signaling, the survival signaling, which is basically an inherited signaling to adapt to ischemia reperfusion injury. So if any of these drugs may block these endogenous cardioprotective pathways, and there has been some preclinical studies showing that nitrate tolerance, for example, and statins, for example, may decrease the post-conditioning effect. So they also causes, let's say, hidden cardiotoxic effect. So, but can we really, use this knowledge if this assumption, if a diseased heart responds differently to the toxic signaling? So therefore, our aim was to set up a kind of a hidden tox testing platform and to explore an effect of a test drug which has been shown already to be hidden cardiotoxic. And we tested this test drug in ischemic reperfusion injury and also cardioprotection by ischemic preconditioning to check whether we are able to catch these hidden cardiotoxicity at the preclinical phase. So there are lots of drugs which has been withdrawn from the market due to unexpected cardiotoxicity. And probably the most well-known is the rofecoxib story. And when the Vioxx was withdrawn from the market by MSD because it caused myocardial infarction, and according to meta-analysis, is also associated with increased risk of arrhythmias and also increased the risk of overall cardiovascular events. And although there were some assumptions how this caused myocardial infarction, but the exact mechanism has been never explored. So as a proof of concept study, we selected rofecoxib as a test molecule to test if in a preclinical animal model, we would be able to show any cardiotoxic effect of rofecoxib if we subject the heart to ischemia reperfusion injury. So we had a very simple experiment. We had 30 minutes of coronary occlusion with reperfusion, so causing myocardial ischemia reperfusion injury and infarction. And also we induced preconditioning to protect this heart. These were the weaker treated groups, and the other same groups were pre-treated with rofecoxib for 28 days. This with this COX inhibitor with a clinically relevant dose of which we converted from human dose to rat dose. And the endpoints were infarct size, mortality, and arrhythmias. And what we have found was a very mixed picture. What was very striking is that ischemia, when the rats were subjected to ischemia reperfusion injury and rofecoxib, much more rats died actually due to rofecoxib treatment, while ischemic preconditioning effect was not affected by rofecoxib at all. However, on the other hand, what we found is that rofecoxib itself decreased in surviving animals, of course, decreased infarct size significantly. So on the one hand, it increased the mortality, but also showed some cardioprotective effects. So we went on and tried to find out what caused the increased incidence of irreversible ventricular fibrillation as maybe the reason behind the increased mortality. And indeed, we found that when the animals were subjected to rofecoxib and ischemia and reperfusion, there were much more incidence of irreversible ventricular fibrillation and other severe arrhythmias as well. To further check what was the reason of this increased ventricular fibrillation, we went to action potential duration measurement in rat isolated papillary muscles. This is also routine safety testing, but without ischemia. So, and what we have seen that in normoxic tissues, normoxic isolated papillary muscles, you see that there was absolutely no effect of rofecoxib. So in the healthy tissue, there is no effect. However, when there was ischemic reperfusion injury, we subjected these papillary muscles to ischemic reperfusion injury. There were a dose-dependent increase in action potential duration, which may cause ventricular fibrillation as well. What was also interesting, actually, that this rofecoxib-induced cardiotoxicity, hidden cardiotoxicity, was preventable by the application of ischemic preconditioning. So it was a very complex picture. So, and to test whether the infarct size reducing effect of rofecoxib was just an artifact because more animals died and only those survived which had lower infarct size. So we tested it also in simulated ischemic reperfusion injury and cardiac cell models. And indeed, here we've shown that rofecoxib treatment protected the myocardial cells from ischemic reperfusion injury. So we confirmed this mixed effect. So on the one hand, there is a pro-arrhythmic effect of rofecoxib due to ischemic reperfusion injury, but on the other hand, it protects the myocardial cells from death during ischemic reperfusion injury. So the interim conclusion is that the hidden cardiotoxicity can be revealed by safety testing in the diseased heart, in this case, in ischemic reperfusion injury, because we showed that there is a pro-arrhythmic effect of rofecoxib, which was also shown by a meta-analysis of clinical trials as well. So we think that it's very important to introduce this early prediction of hidden cardiotoxicity by the introduction of safety testing, not only in the healthy tissue, but also in several diseased tissue, because in this case, we could increase the safety of the preclinical trials. We can save the development time. and also increase the success rate of drug development. And of course, a lot of costs can be saved. But what is the mechanism of hidden cardiotoxicity? So we try to find out if there is a uniform mechanism, or maybe it's just different mechanism by drugs, by different drugs. So we first tested the mechanism of hidden cardiotoxicity induced by rofecoxib with the multi-omics approach. So we did a microRNA and mRNA sequencing of the myocardium after rofecoxib and vehicle treatment, and also did a phosphocyte proteomics and just shotgun proteomics as well. And Bernard Weber's PhD student showed that the mechanism of rofecoxib-induced molecular changes in the heart is very complex. So by showing this network analysis, the protein interaction analysis, the regulation of proteolysis has been changed, the regulation of translation, regulation of mRNA processing, actin cytoskeleton binding, regulation of citric acid cycle, a lot of metabolic effect. And also there was calcium ion handling and electrical conduction changes as well, which may explain the proarrhythmic effect of rofecoxib. So next, what we are doing currently is to test some other compounds which either under development or during clinic or in the market, with, for example, with rosiglitazone, which is an antidiabetic drug, and the cardiovascular risk has been debated by the regulatories. And so we tested this also in the same model. So just vehicle treatment, rosiglitazone treatment, and then comes the ischemic reperfusion injury preconditioning to test if there is any effect on ischemic tolerance. And what we have found that rosiglitazone treatment did not affect acute mortality during ischemia reperfusion injury, and nor it interfered with ischemic preconditioning. So there was a neutral effect. And also, rosiglitazone treatment did not influence the infarct size or interfere with any cardioprotective effect of ischemic preconditioning. So here you see the vehicle and the rosiglitazone treatment. There was a slight but pretty much non-significant increase in infarct size, and there was absolutely no change in the cardioprotective effect of ischemic preconditioning. So what we have found also that rosiglitazone slightly increased cell survival in simulated ischemia reperfusion injury in a dose-dependent manner. So according to these results, rosiglitazone, at least in these preclinical studies, did not show any hidden cardiotoxic effect. And even it showed some cardioprotective effect, but only in cell culture systems, in adult red cardiac myocytes, and also in human cardiac-derived cell line AC16. We also went on and tested bempedoic acid. This is an anti-hyperlipidemic drug, and the same protocol, so ischemia, reperfusion injury, and we used the positive control for ischemic preconditioning. And what we have seen that there is absolutely no significant difference between vehicle and bempedoic acid in terms of arrhythmia score, nor the infarct size, as you see here. And so basically, the vehicle and bempedoic acid had the same infarct size, while the positive control was effective. And we also tested the cardiotoxic effect of bempedoic acid in a simulated ischemic reperfusion injury in the human AC16 cell line. And what we found, basically, that in normoxia or in simulated ischemia reperfusion injury, there was absolutely no change or even less cytotoxic effect with the increased dose of bempedoic acid. So bempedoic acid is also not a candidate for hidden cardiotoxic effect. But since my time is getting over, and it is over, so we are checking some other compounds and including some vaccines as well. And we did found that there is a hidden cardiotoxic effect of the RNA-based SARS-CoV vaccines. There are a paper in British Journal of Pharmacology recently, and we also work on the mechanism of the effects of how the vaccines, these RNA vaccines, induces hidden cardiotoxicity, which is also known from the clinic because they cause several, heart failure and also some cardiomyopathies as well. So as a take-home message, the importance of cardiovascular comorbidities in preclinical drug testing is very important. The mechanism of hidden cardiotoxicity in the diseased heart is very complex, and we have very little data so far on it. And we think that it's very important to reveal the hidden cardiotoxicity of all drug candidates at an early preclinical phase to develop drugs with a better safety profile. And these are our friends and collaborators and our group. Thank you very much for your attention.
Thank you, Peter. Thank you, Professor Ferdinandi, for this wonderful talk. And the discussion will be at the end. Now, I would like to introduce Professor Emilio Hirsch. Professor Emilio Hirsch is full professor of cell biology at the University of Turin Medical School and director of the Molecular Biotechnology Medical Center. So he will talk about doxorubicin, cardiotoxicity, and cardiac metabolic rewriting.
Thank you so much, Rosalinda. Let me just start sharing the presentation. Here it is, and these are also my disclosures. Yeah, we heard already a lot about cardio-oncology, so I don't need to stress this too much. But of course, we know that cancer patients are surviving a bit longer today, and the problem is that they survive so long that now they can start to develop signs of toxicity that we just heard about. And so in the recent past, we focused a lot on doxorubicin, because doxorubicin is still quite useful and quite popular anti-cancer drug, especially in some childhood leukemias, in breast cancer. But it's well known that this drug, besides its fantastic effects in the oncology field, is driving some kind of damage, of tissue damage and cellular damage in the heart. And this is, for example, something happening in mitochondria. So we know that doxorubicin is disturbing the activity of mitochondria, and cardiomyocytes are the cells that probably are the most enriched in mitochondria. So it's easy to understand that doxorubicin is causing some type of cardiotoxicity. The issue is that we see a kind of a specific, we heard a little bit before, but we see some kind of a specific development of the disease. So at a certain stage, initially, the disease seems to be reversible, but quite rapidly, the disease develops into something that is less and less reversible. And in the long run, we actually see irreversible damage of the heart and basically end-stage heart failure. So with this in mind, can we do anything to try to avoid these processes and try to act on the mechanisms driving cardiotoxicity when this is still reversible? And so to try to address this question, we analyzed the transcriptome in a single cell method just a few days after doxorubicin treatment, in a way that resembles the acute cardiotoxicity, and also the phase where the damage seems to be reversible. And I think in this approach, we were able to detect different tissues with different transcriptional changes. And I think it was quite instructive to see that, for example, it's not only cardiomyocytes, but also the environment that changes upon doxorubicin treatment. And quite rapidly, we see that there are some effects in cardiomyocytes, but if we wait long enough, we see in single cell sequencing in the transcriptome of the different populations that we can detect in the heart, that in the long run we have tremendous changes that seem to actually follow in the initial damage. So at 3 days, we don't see much of changes, as you can see here. The transcriptome is more or less the same. And again, this is probably the sign of what is still reversible. But after 6 weeks, then things tend to change. And for example, we see a quite a strong expansion of a population of macrophages. And this population of macrophages is particularly relevant. It's the TREM2 high population, because this population of cardiomyocytes of macrophages is recruited by cells that tend to have metabolic stresses, and cells that, for example, because of dysfunctional mitochondria, tend to develop damaged mitochondria on one side and lipid droplets on the other. So as if the effect of doxorubicin on cardiomyocytes is in the long run changing the immune response. And this, we think, is a part of a loop. So once the immune response is changed, the heart gets more and more in a distress. But let me also now analyze in deeper detail what happens in cardiomyocytes. So we see that even initially after 3 days after doxorubicin, we see that our normal basal cardiomyocytes that are characterized by this orange cloud tend to develop into so-called stressed cardiomyocytes. And this population is emerging quite rapidly, so meaning that changes in the cardiomyocyte transcriptome appear right in that window where the damage might still be reversible. And most of these changes show a kind of a specific developmental path. And I think that with this pseudo-timing, we could quite highlight this effect. And to make the long story short, after detecting many different genes, well, the final outcome is that we see very early on an important rewiring of many different metabolic genes. And so we tried to get into some of these genes in more detail, and we tried to analyze in more detail what this rewiring of the metabolism of cardiomyocytes meant. And so, for example, what we see is that within these changes in the transcriptome, we see an increase acutely after doxorubicin of the expression of CD36, which is a transporter for lipids. And you see that this is also true in terms of protein expression. So as if the cell, the stressed cardiomyocyte after doxorubicin is trying to change its metabolism in absorbing more fatty acids, which is the usual food for cardiomyocytes. But actually the situation is quite different, is much more complex. So if we tend to give lipids to cardiomyocytes before, as you can see here in the control, or after 3 days after doxorubicin, well, you see that there is a quite important change. So in principle, these cells after doxorubicin try to uptake higher lipids because they increase the CD36, but also at the same time we see some kind of accumulation of these lipids. So if you use BodyPI, which is a marker of lipid accumulation, and you see in controls we don't see any accumulation of these lipids because these are the food for the cardiomyocytes. After doxorubicin, well, they tend to accumulate these lipids, so as if they change their menu. So I think that this idea of changing the menu is something that will follow us throughout the talk. And in principle, what we see is that after doxorubicin, well, of course, doxorubicin is disturbing mitochondria. Mitochondria are important for fatty acid oxidation. And so you see that even if they tend to accumulate and internalize more lipids, fatty acid oxidation is going down. And as we detected more accumulation of lipids, we checked whether genes that are involved in lipid accumulation are also modulated and also upregulated right after doxorubicin. And for example, we see that there is a strong upregulation in transcriptional levels of this gene DGAT2, which is a key gene in the organization of lipid droplets, so storage of lipids. Usually, this DGAT should go down for to allow lipolysis, but actually, in this condition, it seems like doxorubicin is inducing higher expression. And again, as I showed you in the picture before, we see that there is an accumulation of cardio-triglycerides. And it seems like if we look now at later stages, what we see is a quite effective accumulation of these lipids, even in vivo. So these are sections of hearts after doxorubicin treatment in mice. And you see that we can stain this triglyceride accumulation with oil red. And after doxorubicin, we see that all these cardiomyocytes are full of lipid droplets, which is counterintuitive because in a way, the heart is always eating up fatty acids, and now the mitochondria are damaged, and they tend not only to stop eating fatty acids, but counterintuitively, they tend to store them into lipid droplets. So we decided to see how this could be connected to mitochondrial function. And in a way, surprisingly, we detected an early response in oxygen consumption that was a bit the opposite of what we expected. So we thought doxorubicin is disturbing mitochondria, so we expect to see a lower in oxygen consumption in the after doxorubicin. But actually, very early on, we see the opposite. We see that cardiomyocytes are responding to this toxic stress by kind of increasing mitochondrial function and oxygen consumption. And then we try to see which kind of foods these hyperactive or partially hyperactive mitochondria were using, and we gave different substrates, and then we analyzed the specific amount of oxygen consumption by all of these specific substrates one by one. And as I hope you can appreciate, beta oxidation, which is lipolysis, is not increased. So it's the oxygen consumption that we detect after doxorubicin is indeed not driven by the eating up of free fatty acids. This is also the same with glutamate and succinate, but actually, if you see, when we analyze the oxygen consumption induced by pyruvate, then bingo, we see that this is the one that increases oxygen consumption. So pyruvate comes from glycolysis. So it seems like cardiomyocytes usually eat fatty acids, but when doxorubicin is given, they change the menu and start to eat glucose, and this glucose goes through glycolysis. And this hypothesis was supported by the data, because you see that we see an increased glucose uptake after doxorubicin, but also we see an increase in the activity of different enzymes important in glycolysis. The interesting point is that usually glycolysis means that the cell is producing lactate if no oxygen is present. But I told you oxygen is present, and mitochondria seem to be more active. So actually lactate doesn't change. And so it seems like pyruvate is channeled right away into the TCA cycle. And so in principle, what we see is that if we give if we do a carbon tracing and we give a C13 labeled glucose to these cardiomyocytes after doxorubicin in vivo, what we see is that rapidly pyruvate is radioactive, and then we see accumulation of all the different substrate in the TCA cycle, indicating again the glucose is turned through glycolysis into pyruvate, but then pyruvate is channeled into the TCA cycle, and there is no change in lactate. Even if we run a kind of a snapshot of what is going on and do some kind of metabolomics in the doxorubicin treated cardiomyocytes, we see accumulation of the different substrate in the TCA cycle. So pyruvate first is accumulated, and so pyruvate is turned into acetyl-CoA, and we see an increase in acetyl-CoA. And because these mitochondria initially kind of increase their oxygen consumption, well, this is likely happening because of an increase in the activity in the TCA cycle. And in the end, because of this increase, the activity in the TCA cycle, we see an increase in the accumulation of the different intermediate substrates. And it is the whole TCA cycle that is hyperactivated, because all different substrates show the same kind of accumulation, despite probably the fact of alpha ketoglutarate is the most abundantly and is the most highly accumulated metabolite. So this means that the enzymes in the TCA cycle must be more active. And one way to control activity in the TCA cycle is through acetylation. So we run some kind of proteomics and acetylation of proteins analysis. And you see that we see after doxorubicin a dramatic change. So we see some proteins that become hyperacetylated, and these hyperacetylated enzymes usually become less active. And so as expected in a way, because fatty acid oxidation is reduced, we see that FAO enzymes are hyperacetylated. But in support of what we were seeing in the TCA cycle, we see that the TCA enzymes are hypoacetylated. So this means again that they are turned into some kind of hyperactive enzyme. So it seems like the cardiomyocytes is turning into a kind of a vicious cycle. So at a certain point, the doxorubicin is causing some kind of damage on mitochondria, but the remaining mitochondria try to catch up. They increase their TCA cycle activity. Acetylation shows a kind of a shift in the menu, and the shift in the menu is also driving some kind of further shift that is probably the cause of the irreversible damage we see in 6 weeks after doxorubicin treatment. But so the issue is how is the cardiomyocyte changing this menu? And then we have some, we ended up with some potential explanations. So in the heart, glucose can be turned into pyruvate through glycolysis, and then pyruvate can be turned into acetyl-CoA. But usually this is not the preferred route. As I told you, cardiomyocytes prefer to use use fatty acid oxidation, and acetyl-CoA actually comes from beta oxidation. But the shift between these two pathways, so the so-called Randall cycle, is controlled by a key enzyme, the PDH enzyme, the pyruvate dehydrogenase enzyme, which is key to transform pyruvate in acetyl-CoA. So usually this enzyme is inactivated by a kinase PDK4, and so that's how the heart keeps the standard menu. So the ability of eating up fatty acids. So in the normal situation, PDK4 is highly expressed. It's a kind of a constitutively active kinase. It's constitutively active. It's constitutively phosphorylating PDH, and so PDH is unable to turn pyruvate into acetyl-CoA. But PDK4 is transcriptionally regulated because it's a constitutively active kinase. And a key regulator of PDK4 expression is FOXO1. And FOXO1 is also target of some other signaling pathways upstream, and particularly PI3 kinase, which is, of course, the enzyme that I've been working with for so many years now. And so as you see here, PI3 kinase is actually inhibiting FOXO1. And so with a condition where FOXO1 is inhibited, so PI3 kinase trigger AKT phosphorylates FOXO1, and FOXO1, when phosphorylated, is degraded. So FOXO1 is then not able to control PDK4 activity. And so you see the shift. So basically now PDH is free to activate the transformation of pyruvate into acetyl-CoA. And so basically the cardiomyocyte starts to eat pyruvate instead of fatty acids. And in the past, we showed, Alessandra Gigo showed that there is a response, a stress response in the cardiomyocytes after doxorubicin that involves a lot of different genes, including one PI3 kinase. And this PI3 kinase gamma, is heavily upregulated when hearts are subjected to doxorubicin treatment. And here you see in a section of a patient with doxorubicin-induced cardiomyopathy, the staining for PI3 kinase gamma is significantly higher. So PI3 kinase gamma could in principle drive this effect. But also at the same time, we went back to our single cell transcriptome analysis in cardiomyocytes, and what we actually could see is that indeed, in line with this kind of a model that I showed you before, we see the PDK4 expression goes down quite rapidly in cardiomyocytes after doxorubicin treatment. So basically, doxorubicin triggers PI3 kinase, and PI3 kinase then blocks the PDK4 activity, and so we have PDH that turns the pyruvate into acetyl-CoA. And so we also have mice that express a catalytically inactive PI3 kinase gamma. And what we see is that after doxorubicin, these mice cannot activate or actually induce phosphorylation of FOXO1, which is not an activation. It's actually an inhibitory phosphorylation event. So FOXO1, once phosphorylated, goes out of the nucleus and is degraded. So without the PI3 kinase activity, FOXO1 is less phosphorylated, and at the same time, we see an increase in PDK4 mRNA levels, and at the same time, we see an increase in PDH phosphorylation, which means that the activity of PDH, when PI3 kinase gamma is inactive, the blue bar, you see that the PDH activity goes down to normal. So we can kind of restore the standard menu when we reduce PI3 kinase gamma activity. And this is truly functional, because if we look at the oxygen consumption in hearts from kinase dead mice, where PI3 kinase gamma is not active, then we see that they tend to consume less oxygen after doxorubicin treatment. And also, in the long run, having an inactive PI3 kinase gamma is protective. And here it seems like the damage is low, but look at the mitochondrial DNA content in these heart slices. In the long run, 6 weeks after doxorubicin injection, well, you see that the amount of mitochondrial DNA is significantly increased. So we can easily imagine that the effect, if we look at if we normalize for the same amount of mitochondria, the damage would be much more striking. And also what we see is that in the condition of no PI3 kinase gamma activity, this down regulation of oxygen consumption is completely avoided, even at longer terms. And this is also detectable by another way of measuring cardiac damage due to mitochondrial hyperactivation, so lipid peroxidation. You see that in wild-type hearts, doxorubicin induces strong lipid peroxidation, but this is quite reduced when PI3 kinase is inactive. But also, I think that we not only have PI3 kinase gamma as a potential target, because unfortunately we don't have yet PI3 kinase gamma specific inhibitors, but we have some other drugs, and there are some very interesting drugs that can act perhaps in desired ways. And this drug that is becoming so popular now, gliflozin, is protecting the heart for sure, but is also reducing glucose in the blood. And so, as you see, with the doxo, we increase the flux of pyruvate, but if we reduce glucose in the blood with empagliflozin, we reduce pyruvate as well. And we can protect again the effect, the toxic effect of doxorubicin. In this cohort of mice, the toxic effect is more striking. And this is again 6 weeks. And you see that with this treatment with empagliflozin, we are able to restore normal oxygen consumption, probably by telling cardiomyocytes, look, you want to use glucose as a stress response, but there is no glucose around, so please go back to your usual menu. And I think that this is importantly effective on cardiac function, because again, empagliflozin has a cardioprotective effect. This is already in clinical use, and so perhaps this is a sign that this can be used in patients with doxorubicin-induced cardiotoxicity, because you see we can improve fractional shortening, we can reduce the effects of doxorubicin overall. So I'm stopping here. I think that we found some key players in this vicious cycle that is triggered by doxorubicin, and that goes from a reversible to an irreversible cardiac damage. And probably by playing with some of these reversible players in the reversible stage, we can protect patients. I want to thank the people that got involved in the project, in particular Sandra Gigo, that ran most of the experiments and the hypotheses that I presented to you today. And I want to mention Giulia Guerra and Marco Mergiotti that also worked hard for this project. And I want to thank you all for the kind attention.
Thank you very much, Emilio, Professor Hirsch, for this very wonderful talk. And now we can start the discussion. I would like to start the discussion with the 3 questions to the 3 main speakers. Okay, the first one to Emilio. Emilio, what do you think if there are some effect of the environmental risk factor, including genetic risk factor, genetic background on the DOXO-induced genetic rewriting, and what is the role of autophagy in the mechanism of EMPA, in the cardioprotective mechanism of EMPA in the DOXO-induced heart failure. Then to Professor Ameri, to Pietro. Pietro, do you think that the role of the endomyocardial biopsy can help in the early diagnosis of and in the etiological diagnosis of IC-induced myocarditis? Because we often think that IC-induced myocarditis are induced by an autoimmune or immune-mediated mechanism. However, some mechanisms are still unknown, so the endomyocardial biopsy could help address the therapeutic choices. And the last question to Professor Ferdinandi, what would be the role of genetic predisposition, genetic background on the hidden cardiotoxicity, and therefore its role in the early diagnosis of this hidden cardiotoxicity?
Who is answering first?
I think,
Should I
Emilio,
start with
you are the last.
Thank you.
You are the last,
Okay.
but the first, not the last.
Thank you. So going first to genetic predisposition. Well, of course, genetic predisposition is playing a major role there. I'm sure that Peter is going to also add to that a lot of interesting issues. But there are a lot of genes that seems to be connected to doxorubicin cardiotoxicity. We don't know if the genes I talked about are specifically involved in genetic terms, but there are a lot of other genes. Autophagy is a fantastic question. I think autophagy is playing a major role there, particularly mitophagy, because when the cardiomyocyte is eating up damaged mitochondria, is helping the healthy mitochondria to stay, and I think this part is an essential response that the cardiomyocyte is setting up, and so autophagy is playing a major role there. I saw that there was a question in the chat, and I mean, does doxorubicin increase fatty acid synthesis? Well, I don't think so. I don't think it's increasing the synthesis, but it's increasing the accumulation. So the heart likes to uptake fatty acids, but doesn't necessarily like to produce fatty acids. Actually, usually it doesn't produce any fatty acid at all. But the issue is that it seems like after doxorubicin, the heart is responding to a stress that is reorganizing the diet, and so the heart stops to eat fatty acids. So, but fatty acids are still there, and so because it's less able to metabolize these substrates, it tends to accumulate then in lipid droplets.
I think there is another question from the connected remotely people about dexarosum in protecting cardiotoxicity induced by doxorubicin.
Yeah, that's a very interesting question too. I'm not a super expert of iron metabolism. Dexrazoxane is supposed to be an iron chelator, but this is also debated because it seems like this drug has some kind of intrinsic cardioprotective activities that are still not very clear. So I would say that dexrazoxane is acting on two ways. It is probably chelating iron, which is reducing mitochondrial damage, but at the same time is also provoking some kind of a cardioprotection that we don't understand yet.
Okay, Pietro, would you
Yes.
take the discussion?
Yes, answering your own question, yeah. So the diagnosis of immune checkpoint-related myocarditis is follows the same workup as the diagnosis of any type of myocarditis. So clearly, the gold standard would be an endomyocardial biopsy, which however is dangerous. I mean, implies some risk and may not be doable in any setting at any moment. So the alternative is a cardiac MRI, which is highly sensitive and specific. And there are criteria established by the International Cardio-Oncology Society and the European Society of Cardiology, according to which the increasing cardiac troponin concentration, along with consistent changes on cardiac magnetic resonance imaging, are sufficient to diagnose immune checkpoint-related myocarditis. So as a rule of thumb, there is no need to perform endomyocardial biopsy. Then it is suggested to do the biopsy anyway in those cases that are severe, with very severe presentation, or with a crash and bar clinical course, where you really need to be 100% sure that the diagnosis is immune-mediated myocarditis, because you need to be sure that the immunosuppressive therapy is correct. The other context where you may want to do an endocardial biopsy is if you are also collecting information for research purposes, but this, of course, should be within an approved clinical study.
Thanks.
Yeah.
And then the last one, Peter, from my side.
Yes, so if there is any individual genetic predisposition, we don't have data on it, but I'm sure yes, because we think that it's similar to cardioprotection. So a drug can be either cardioprotective or cardiotoxic during ischemia reperfusion or in any other cardiovascular comorbidities. And we know that in cardioprotection, there is an individual response even in healthy animals to cardioprotective signaling, and there is a genetic predisposition to it. And also, ischemic reperfusion injury itself causes huge genetic changes with changes in mRNA and non-coding RNA. Fingerprint is totally different, and hundreds of genes are changing. So this is very complex. So I think that cardiotoxicity is also an individual response to the drugs.
Thank you.
Thank you.
I also have a couple of one question open to Professor Ameri and Professor Ferdinandi. So what I ever heard is that reverse cardio-oncology is quite timely in the field of cardio-oncology. So I would give some perspective. So I would like to ask you, what are, for in your opinion, the next step, the roadmap for address the role of existing cardiovascular, cardiometabolic disease in the field of cardio-oncology? So how to improve the design of randomized clinical trial or clinical study, how the difference in analyze them, and what are the perspectives in testing new drugs? I don't know, we must include some people with persisting cardiovascular disease before testing drugs. Thank you.
So who starts?
Who's done first? May I try to answer?
Sure.
So, well, I don't have an answer. This is my answer. I can just repeat what I said at the conclusion of my talk. So the wider is the view in cardio-oncology, the greater is the challenge to put everything together, of course. And the reverse cardio-oncology has a greater view as compared with traditional cardio-oncology, so it's more challenging. And if you add factors, the difficulty will become greater. So if you had obesity, if you had social determinant of health, whatever, it will become more and more difficult. And I don't think, honestly, that anyone will ever be able to perform conclusive studies on such a huge topic by his or her own. You don't have the forces, and no one will ever have the forces. The only way is to try to harness the data that can be obtained by studies that are indirectly related to bidirectional cardio-oncology. So I think that as a group of researchers and clinicians involved in cardio-oncology, we should do our best to promote the adoption of minimum data sets that are used across different studies and trials. That's the only way to exploit information in a very opportunistic way, even when the information is not collected for the purpose of reverse cardio-oncology. Otherwise, I think that the challenge is, stimulating, like all major challenges, but the risk of failure is incredibly high.
Really, I agree, totally agree.
Yeah, and I just add something that I think that for drug development and safety testing, the inclusion of the usual comorbidity picture in preclinical models is extremely important. So not only in cardiac protection, but in any diseases, basically. So we have written several reviews and pharmacological reviews on it, but now we're seeing that not only cardiac protection needs it, but also cardiotoxicity testing needs, because each patient with different comorbidity profile may respond differently to different drugs. So there's a long way to go to gather data on these.
Thank you.
Okay, I don't think that there are any questions from those who are connected remotely. So I would give my final messages. This was a very interesting webinar on three main topics that are very important in cardio-oncology. The first one is the preclinical and clinical research. The second one is the hidden cardiotoxicity. And then the third one is the metabolic rewriting in the patients treated with doxorubicin. And I think there were a lot of questions, very topics question, also from the audience. The webinar was very well attended. And I would like to thank all the speakers, my co-chair, Professor Carbone, and MDPI for organizing this special webinar. And then I would like to give the final home messages to Professor Carbone.
So there were three very outstanding talks, and I would like to MDPI to organize this webinar and to join me as co-chair. And I'm really excited about the potential of advancement in cardio-oncology, not only for this specific topic, but all the potential next step that may give to clinical research.
And let me thank the organizers for this great opportunity. Thank you.
Thank you. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you very much. It was fantastic.
Thank you, Amy. Thank you, MDPI. So there are a lot of messages now coming.
Yes, thank you.
Thank you very much to our class and all our speakers. That was fantastic.
Thank you for the invitation.
Thanks. Yes, bye-bye.
Okay.
Goodbye.
Okay.
Goodbye, everybody.
Bye.
Bye. Thank you. Grazie, Rosalinda. Bye-bye.
Grazie a te, Emilio. Grazie, Pietro. Grazie, Peter. Grazie, Federico.